Can't see anything yet. Wait a second. Maybe it's back here. Ah, here it is. Okay.
Good.
Good. Good. Okay, so
Okay.
attendees, we should mute all. All right. Go ahead. Oops. Sorry. Julia, can you hear me now?
I can, yeah. Right.
Okay.
I'm going to talk about the causes and management of severe maternal outcomes. The objectives of the lecture this evening are to recognise the symptoms and signs of major hemorrhage and pre-eclampsia and eclampsia, and to understand the anaesthetic management of major hemorrhage and pre-eclampsia, and to understand their role in morbidity and mortality in the context of Palestine. The WHO describes maternal death as the death of any woman while pregnant or within 42 days of being pregnant. A maternal near miss is defined as a woman who nearly died but survived a complication, and severe maternal outcomes are maternal near misses and maternal deaths. And as your maternal death rate falls, which it is in Palestine, the number of maternal near misses increases, and they are harder to capture because they don't have the definitive endpoint that the death does. So if we look at deaths in the UK, in the last confidential inquiry, the major causes of direct death were hemorrhage, preeclampsia, thrombosis, sepsis, and amniotic fluid embolism. And we're also going to talk about influenza tomorrow, which is the most important indirect cause of death. If we look at deaths in Palestine in 2009, the direct causes were, again, pulmonary embolus, bleeding, eclampsia, and ectopic pregnancy. And a large number of the indirect causes of death were from the influenza virus. So, the big four, or in this case the big five, are hemorrhage, preeclampsia, thrombosis, sepsis, and influenza. Hemorrhage is the most common cause of maternal death worldwide, and it is also responsible for 36% of all obstetric patients who are admitted to the intensive care unit in the UK. The definition of hemorrhage can be described either in terms of time or volume or cause. Massive hemorrhage is defined as more than 1,500 mils, but perhaps more usefully than defining hemorrhage in terms of cause or time is the question, is the hemorrhage arrested, has the hemorrhage stopped, or is the hemorrhage ongoing? Because a 1,500 ml or 2 litre hemorrhage that is stopped is really not the same problem as a 2 litre hemorrhage which is continuing. As I said, the causes of hemorrhage can be defined in several ways. Antepartum, eruption of the placenta, intrapartum, abnormal placentation or a ruptured uterus, and postpartum, 4 T's. Tone, that is atonic uterus, tissue, retained placental parts, trauma, laceration to the uterus or genital tract, and thrombin causes, coagulopathy, such as amniotic fluid embolus. However, the definitions are a little artificial because what starts as an antepartum hemorrhage may continue as an intrapartum hemorrhage and finish as a postpartum hemorrhage. And the old adage is an empty, intact uterus will not bleed. So, if we look at the symptoms and signs of hemorrhage in the pregnant woman, we talked in the last set of lectures about the physiological changes that occur within the pregnant woman in the cardiovascular system and in the coagulation system. These are designed to allow a woman to bleed at least 500 mils without showing any signs of a compromised cardiovascular system. So as you can see from this illustration, it is quite easy for a pregnant woman to lose at least 1,000 mils before she gets a significant rise in pulse. She will have bled at least 1,500 mils before her blood pressure drops. And a pregnant woman or a recently pregnant woman who is tachycardic and hypotensive has lost a significant amount of blood. A working volume would be at least 2 litres. So this is a very simple representation, but it is important to remember that just because a woman's pulse and the blood pressure are normal, it does not mean that she has not bled. As you can see from this chart, this is called a maternity early warning score chart, and is essentially a pulse and blood pressure chart, which is color-coded so that the person who is measuring the pulse and blood pressure, who may not understand the significance, knows that they have to call for a medical review if any of the parameters go into the red zone. So, what is the first thing that must happen if someone is having a major hemorrhage? Well, in the UK, that is the attendance of the most senior person on duty, that is the consultant. This is an excerpt from our delivery suite guidelines in my hospital, and it is absolutely essential and mandatory that a consultant obstetrician and a consultant anaesthetist must attend for a postpartum hemorrhage of over 1,500 mils if the bleeding is continuing. The graph above illustrates the consultant attendance in eclampsia cases, but it could just as well be for hemorrhage cases, since this was mandated in the UK. This is data from the Scottish confidential inquiry. And although anaesthesia is lagging behind, it's certainly the consultant obstetrician will be in attendance at a major hemorrhage. And it is very important that you assemble the most experienced team that you have available to deal with this life-threatening emergency. The treatment strategies for major hemorrhage are simple in some respects. Replace the losses, avoid disseminated intravascular coagulopathy, and arrest the cause of bleeding, that is, turn off the tap. It's well known for at least 20 years in the trauma environment that the combination of hypothermia, acidosis, and coagulopathy are a lethal triad, that is, they are killers. So the treatment strategy that you will seek to employ as the anaesthetist is to avoid these 3 things. Avoid hypothermia, acidosis, and coagulopathy. And we'll go through each of these in turn. So you need to have the right equipment. You need at least 2 16-gauge cannulae. You need wide bore giving sets. It's no good having large cannulae if you have a narrow giving set through which to give your fluid. I'm not going to go into the details of the Hagen-Poiseuille formula, but enough to say that we all remember that flow rate is proportional to the radius of the tubing or the cannula to the 4th degree. So a very small increase in the radius of the cannula will increase the amount of blood or fluid that you can put into the patient quite significantly. Sometimes, if you have a woman who is severely collapsed and on the edge of cardiac arrest from hypovolemia, you may wish to consider an interosseous needle. You also need a method of infusing the fluid under pressure. Simple pressure bags are enough if you don't have an automated system such as a level 1 infuser. So this is a picture of a woman who delivered in my hospital a few weeks ago. She was moribund with hypovolemia. She had previous difficult access, intravenous access, because she'd been an IV drug user in the past, and she was too underfilled to be able to get anything in her neck, in her internal jugular. So we placed an interosseous needle in the head of her humerus, and it was a life-saving measure. You can take out group and save sample. You can put any drugs you like down the interosseous needle. Propofol, oxytocin, antibiotics, adrenaline, you name it, it can go down the interosseous needle. So I would recommend that you go on YouTube and look up intraosseous insertion in the humeral head and familiarize yourself with this technique. If you don't have a drill, the old-fashioned corkscrew needle arrangement works just as well. This can be life-saving in the case of maternal collapse from exsanguination. Avoiding coagulopathy is absolutely essential, and this is where you, as the anaesthetist, can make a difference between a woman being successfully resuscitated with the minimum sequelae of a massive transfusion by your actions at the top end of the table. It is important to restrict the volume of clear fluid that you give to the woman in the initial resuscitation phase. Restrict it to 1500 mils. If you give litres and litres of clear fluid, not only do you put your patient at risk of getting pulmonary edema, but you cause a significant dilutional coagulopathy, which you wish to avoid, because it's all about avoiding the hypothermia, the acidosis, and the coagulopathy. In the interim period, while you're waiting for the blood to arrive from your blood bank, vasoconstrict your patient with, for example, phenylephrine. And it is very, very important that you try and warm the fluids from the outset of the hemorrhage. You may not have a blood warming machine. You may have to improvise. For example, in this case, you have a bucket filled with warm water. I'd suggest the introduction of a thermometer into the warm water. But if this is the equipment that you have, then you need to use it, because warming the fluid judiciously is very crucial to getting a good outcome when you're faced with a massive hemorrhage. If you drop the body degree by 2 degrees Celsius, so if you go down to 34 degrees C, you will drop the coagulation potential of your patient by 20%, because the enzymes don't function appropriately at the lower body temperature. You then need to tell your blood bank that they have a major hemorrhage, a major obstetric hemorrhage on their hands. Now, this is an example from my hospital, and I'm sure you have them available in your hospital, because you're used to dealing with situations of major hemorrhage, say, for example, in trauma cases. If the situation is entirely desperate and you need to replace volume there and then, after your 1500 mils of clear fluid, you may wish to use the O negative blood. It is important that you know where it is kept and that you tell the laboratory that you have used it. Then you need to get at least 4 units of red cells and 4 units of FFP. Moving on to the second major hemorrhage pack, 4 units of red cells, FFP and platelets. After giving 8 units of red cells and FFP, you need to add cryoprecipitate in empirically. Ideally, you would send clotting samples to the lab and get back information regarding what sort of clotting products you need to give the patient. However, in real time, this does not work. And again, in an ideal situation, you would have access to a thromboelastograph. We don't in my establishment, but if you do, it's a very good guide to whether you need to give cryo, FFP or platelets. Give all women having a major hemorrhage tranexamic acid. It has been shown to reduce the amount of bleeding in normal delivery and at cesarean section. There's a large international multi-centered trial going on called the Woman Trial, which is looking at the dose and the effect. The results aren't out, but is very probably going to recommend that tranexamic acid is used in all cases of major hemorrhage. In the UK and in the States, we have access to recombinant factor 7A, which will cause a big fibrin burst. However, it's not used very regularly, and it needs to be used before disseminated intravascular coagulopathy sets in. Otherwise, it doesn't work properly. And it also puts your patient at risk of thromboembolic phenomena after the hemorrhage has finished. So, transfusion ratios. And this is an excellent article that appeared in JAMA in February of this year. And it showed that if you give your blood, your platelets, and your FFP in a 1:1:1 ratio, within the first 2 hours of the hemorrhage, there are far fewer early deaths compared if you give the traditional recommended transfusion pattern of one blood, one FFP, and then only after several rounds of that giving platelets. If you think about the coagulation cascade, platelets are absolutely necessary to initiate the formation of a clot. Also, your patient is not bleeding just red cells and just FFP, so it does make sense but it also makes scientific sense now that you replace the blood products in the ratio that they're being lost. So I'd recommend that you read this study, as it is extremely interesting and pertinent to major obstetric hemorrhage.
Julia?
Yes?
Can I interrupt for a second? Is there any way you can post this article, the link to this article, on the Palestine anesthesia residents web Facebook page? Because I'm sure most don't have access to the current issues of JAMA. That's the Journal of American Medical Association, incidentally. If you could, as soon as you finish the lecture, if you could post it, or email the link to me and I'll post it. It doesn't matter.
No problem. I'll do that. It's a really, really good article, and it makes we use the phrase common sense, but it is common sense that if you're bleeding whole blood, then you need to replace with the clotting factors and the platelets that you're losing. But this actually shows it scientifically. It's a well done study. So, if we're moving on to the third phase of managing major obstetric hemorrhage, that is turning off the tap. So, a bit like the WHO analgesia ladder, there is a prescribed method of giving uterotonics for atonic uterus. You need to give 5 units stat. We discussed in the previous lecture how there is a ceiling effect with the dose of oxytocin, and that you don't get any more uterine contraction with a dose over 3 units. Currently, the recommendation in the UK is 5 units as a slow IV bolus. You then to give oxytocin 20 units over 4 hours. Now, I understand in this country that sort of the starting dose is 10 units as a stat dose, and then 20 units in about the next half an hour. The only thing that you're gaining from doing that is not further uterine contraction, but you are gaining coronary artery vasospasm. So this is the dose of oxytocin that I'd recommend that you use. You then need to move on to the second line uterotonic, which is ergometrin, given in a dose of 250 or 500 mics IM, and then moving on to carboprost, 250 mics IM. You can give that every 15 minutes. It's important to consider whether your patient has asthma, because if they do, ergometrin and carboprost are relatively contraindicated. And if you are in the unfortunate situation where your patient has pre-eclampsia or eclampsia and an atonic uterus, you need to exercise extreme care before giving ergometrin, because you can precipitate a hypertensive crisis and intracerebral bleed if you use it in that circumstance. So, we haven't mentioned the obstetricians so far in the management of major hemorrhage, but they are key to the management because they need to stop the bleeding. So for uterine atony, they are able to introduce an intrauterine balloon catheter, which helps the uterus contract down onto the catheter and can maintain uterine contraction. They have various surgical maneuvers, such as a B-linch suture. So if you imagine a belt and braces being applied around the uterus, the surgical sutures will actually keep the uterus contracted. And combined with the Bakri balloon, the two things can work very well to counteract severe uterine atony along with your uterotonics. There are various hemostatic surgical techniques that they can use, such as internal iliac artery ligation, and if these fail, surgeons may wish to move on to a caesarean hysterectomy. In the UK, there was a thorough review of all cases of PPH involving caesarean hysterectomy. And the conclusion was that the decision to do a caesarean hysterectomy needs to be taken sooner. So rather than it being seen as management of last resort, it should be thought of as management earlier so that the outcomes are better. And the surgeon may wish to involve gynecology surgeon, say an oncology gynecology surgeon, because it's a difficult procedure to perform. And if they're ligating iliac arteries, they may wish to involve a vascular surgeon. This graph shows that since the recommendation in the UK to perform the caesarean hysterectomy sooner, that actually they've achieved better outcomes from the hemorrhage. So, to summarise the key treatment points, the anaesthetic management of major hemorrhage, it is essential to avoid dilutional coagulopathy. It is also essential to avoid temperature-induced coagulopathy. You need to replace the blood loss in a 1:1:1 ratio, red blood cells, FFP and platelets. This is something that's just changing in the UK, so it will take cooperation with the haematology department to make this change. But if you are faced with major hemorrhage that is ongoing, I can thoroughly recommend to you that you replace the blood loss with red cells, FFP and platelets in the 1:1:1 ratio. It is important it is essential even to use your uterotonics in a logical and stepwise fashion, and the obstetricians play an absolutely vital role in the surgical management of the hemorrhage, with recourse to early caesarean hysterectomy if necessary. Now I'm going to move on to preeclampsia, which is the second biggest killer of women worldwide. Not only is it the second biggest killer of women worldwide, it is also very common in the severe obstetric outcome near-miss category. In the whole of the world each year, it kills at least 60,000 women. But something that we don't think of necessarily as anaesthetis, it is the leading cause of prematurity and low birth weight babies, which is in turn responsible for significant perinatal mortality and morbidity, and if we think economically, a massive burden on the health economics of every country supporting these very small premature babies. Preeclampsia is now seen as what is known as a stress test for later in life. So every woman who gets preeclampsia whilst pregnant will be guaranteed to get hypertension later in life. So ideally, all women who get preeclampsia in pregnancy should be followed up for life, so that when they start getting their hypertension later in life, this can be treated early before there is any end organ damage. So, preeclampsia is the old-fashioned term for blood pressure and proteinuria in pregnancy. Your patient may have hypertension before she got pregnant, so she may have chronic hypertension. She may get gestational hypertension in the way that you can get gestational diabetes. So this presents after 20 weeks and there is no significant proteinuria. Or she may get preeclampsia, which presents after 20 weeks and there is proteinuria. Preeclampsia begins when the placenta embeds itself in the uterus. So it's a process that begins from conception. However, 95% of the time that the woman has preeclampsia, it's symptomless. It's only detected by screening, that is, measuring women's blood pressure regularly antenatally and checking their urine for proteinuria. It then rapidly develops from being asymptomatic into being very symptomatic and may result in a crisis such as that is the eclamptic fit. So it's a spectrum. There's preeclampsia, moving on to eclampsia, and HELLP syndrome, hemolysis, elevated liver enzymes, and low platelets. A big spectrum. The mortality from HELLP is very high. It is a very severe disease that requires a great deal of support and good treatment to enable your patient to survive. The definition of hypertension is 140, a systolic of more than 140, plus or minus a diastolic of more than 90, and the involvement of another system. So proteinuria, renal insufficiency, liver disease, neuro problems, hematological such as the low platelets, and the fact that the placenta is not functioning adequately, that you're going to get IUGR. All of these effects are placental mediated, and essentially you get arterial vasospasm all over the body and leaky capillary membranes. Not all women with preeclampsia will necessarily display hypertension, proteinuria, and edema. So it is known as the Great Pretender, and it is a question that you should ask yourself: of all unwell pregnant women, could this be preeclampsia? And until you have proved it is not preeclampsia, you must consider this as your number one working diagnosis. So, what do women with preeclampsia die from? If we look at the deaths in the UK from 2006 to 2008, the majority of women die from intracerebral vascular events, so cerebral ischemia, subarachnoid hemorrhage. They may die directly from the eclamptic fit. They may have a ruptured liver or liver failure. But if you look at the figures worldwide, there are a large number of deaths from pulmonary complications. However, in the UK, in the last 10 years, since the adoption of national guidelines, there have been no deaths from pulmonary complications, which is remarkable. It shows the effectiveness of developing a national guideline, auditing it, and raising the standard and uniformity of care for these women. However, looking at all the causes, all the patients who died of preeclampsia or eclampsia in the UK, over half of these patients, their care was classified as substandard. So even though we know what is the right thing to do to treat these patients, in over half of these women who died, the right thing, the correct protocol, the correct management was not followed.
Julia, can you speak up a little bit more?
So,
get closer to the microphone, please. Just
okay.
Tough time. Yeah, I'm just having a tough time with the recording. That's all. Thank you.
Okay. So, a systolic blood pressure of 160 millimeters of mercury is an emergency. It is as much an emergency as a cord prolapse is, or a VF arrest. Deaths from intracranial hemorrhage, the largest cause of death from preeclampsia, are consequent to failing to control the blood pressure effectively. End of. Bottom line. It is an emergency. It needs treating there and then, not in 2 hours, not in 4 hours, not when Dr. X comes along, but it needs treating there and then. There are various cut-off points for whether you have oral hypertensives or go on the preeclampsia protocol, and you need to consult the cut-off points in your establishment. Now, there are many preeclampsia treatment protocols, and you can take your pick about which one to use, but they all say the same thing. There is the WHO protocol, the ACOG protocol, and the UK NHS NICE hypertension in pregnancy protocol. They all say the same thing, that the management of preeclampsia must be protocol based. The patient must be managed on delivery suite or in an obstetric high dependency area. There must be aggressive blood pressure control, strict fluid balance, and the patients must be given magnesium sulfate. The hypertensives that we use in obstetrics are old-fashioned hypertensives that aren't used in many other areas of medicine. So if we think about hydralazine, the drop in blood pressure that you get is dependent on the BP to start with. So the higher blood pressure you have to start with, the more the hydralazine will drop your BP. If we look at labetalol, it drops your BP in a dose-dependent fashion. It avoids reflex tachycardia because of its mixed receptor efficacy, and it is advantageous to maintaining cerebral circulation and autoregulation. When hydralazine and labetalol are inadequate, you may wish to move on to use nifedipine, and in exceptional circumstances, a nitrate such as GTN or sodium nitroprusside. The fluid management is absolutely key to obtaining good outcomes in these patients. Patients with pre-eclampsia who are receiving IV antihypertensives need to have their fluids restricted to 80 mL an hour. This is 80 mL an hour in total, all infusions, all oral intake, everything, no more than 80 mL per hour. The amount of fluid given will not avoid whether your patient goes into renal failure. So you will not avoid renal failure by giving your patient more than 80 mL per hour of fluid. The renal failure is consequent on the pathophysiology of the pre-eclampsia itself, and fluid management alone will not stop it happening. If your patient with pre-eclampsia bleeds, it is okay and necessary to replace the hemorrhagic loss. Although the role of central venous pressure measurement has been called into question in the routine ITU and surgical setting, this is one setting where it is actually still quite useful in when you have someone with severe preeclampsia who has bled and you're trying to titrate in the hemorrhagic loss and avoid pulmonary edema. We know that already the capillary membranes are leaky. Oxytocin, which is released naturally at the birth of the baby, and of which we give a bolus at the birth of the baby for the management of the third stage of labour, will reduce your plasma osmolality further. Therefore, the flash point for your patient developing pulmonary edema is in that first half an hour after the birth of the baby. So you need to be vigilant at that point in time to look for and treat pulmonary edema. If we move on to fit prevention and management, magnesium sulfate is the key to this. You can give magnesium sulfate to avoid fitting. You will treat several patients extra to avoid one patient fitting. But because magnesium is a relatively benign and safe drug, it's okay to treat those extra patients. For the termination of fit, you need to give an initial loading dose of 2 grams, that's 20 mils of 10%, over 5 minutes, and then a second loading dose of 2 grams over the next 10 minutes. You then need to go on to a maintenance dose.
Julia, Magdi Al-Baradi has a question.
Okay.
Magdi?
Julia,
Yeah.
do you hear me?
Yeah, she can hear you.
Okay. Can you reply the slide that speak about the antihypertensive medications that we can use it, hydralazine and the labetalol?
Yeah. What's the question?
Can you repeat the slide about the labetalol and the hydralazine?
Okay. So, the 2 antihypertensives that are standard for pregnant women with preeclampsia are hydralazine. The hydralazine will drop you, the higher your blood pressure to start with, the more the same dose of hydralazine will drop your blood pressure. In contrast with labetalol, the amount that the dose of labetalol will drop your blood pressure is dose dependent. So if you give more labetalol, you will drop your blood pressure further. Does that clear the matter up?
Yeah, it's clear now.
Thank you.
Yeah, okay.
Okay, so bottom line, give your patients magnesium to avoid fitting and give your patients magnesium to terminate the fit. There is the differential diagnosis of FIT in pregnancy may be complex. However, whatever the cause of the FIT, you need to assume that it is preeclampsia and eclampsia until proven otherwise, and magnesium will terminate the FIT, whatever the etiology of it. Now, moving on to delivering your patient. Your patient may need delivering for a number of reasons. That placental blood flow is critical and the fetus may be about to die unless it is delivered. Hence, a lot of these women may get delivered very early. It's like 28, 30 weeks. Ideally, neuroaxial blockade, essentially a spinal, is the anaesthetic of choice for delivery. And an epidural for pain relief in labour is also helpful on a number of levels. Pain in itself will put your blood pressure up. Giving a spinal or a high dose epidural will cause a sympathectomy, which may drop your blood pressure a little. However, often these patients are so vasospastic that it doesn't drop your blood pressure. However, a neuroaxial blockade is contraindicated if there is a coagulopathy. So, in summary, it is the preferred anaesthetic for caesarean section if your platelets are normal, but it is important not to fluid load your patient as you would a non-preeclamptic patient, because this will just put them at risk of pulmonary edema, and they tend not to drop their blood pressure once you put the spinal in contrast to patients without preeclampsia. So, you may have to give a general anaesthetic for caesarean section in a woman with preeclampsia or eclampsia. This is a woman who I looked after, who had fitted in the community in her home and then fitted again once she came into hospital. As you can see, she'd bitten her tongue and had gross airway swelling and edema. So, the patients you need to give a GA for are often the sickest patients. They may have airway issues. It's absolutely essential that you put an arterial line in before you start anaesthetizing these patients. And the point of vulnerability is the hypertensive response to laryngoscopy and the emergent hypertension on extubation. If you have remifentanil, a short-acting, very powerful opioid, then this is the time to use it to avoid the hypertensive response to laryngoscopy and to avoid emergent hypertension. You can give a 320 microgram stat bolus followed by an infusion. If you do not have remifentanil, which you may not do, then you will have to use a large dose of fentanyl. Your neonatal colleagues will not like this. However, you need to prioritize the health and the life of the woman above the fact that the neonate may need ventilating or some naloxone because of the apnea related to their opioid dose. We normally advise trainees to extubate pregnant women once their swallow reflex has returned. However, this could be an argument for extubating your patient deep to avoid the emergent hypertension. So, the key treatment points for preeclampsia are: it is essential that you aggressively treat the hypertension. A systolic blood pressure of 160 is an emergency. Like I say, as much as an emergency as a VF arrest or a cord prolapse. Give these women magnesium to prevent fits. Give them magnesium to terminate their fits. And to avoid any deaths from pulmonary complications, you need to restrict their fluid to 80 mL per hour in total. So, we've gone over the two major causes of maternal morbidity and mortality worldwide today. That is hemorrhage and preeclampsia. As anaesthetists, we can make a key difference to these women's outcomes. And the way you do that is by having initially a institution hospital-wide protocol, then a country-wide protocol, and as individuals giving the anaesthetic, you need to pay very close attention and detail to the anaesthetic management to improve the outcomes. Thank you very much.
Questions? Ow! I bumped my knee, sorry.
Okay.
Julia, tomorrow you have to leave fairly early for the... oops, sorry. I have to unmute everyone. I think everyone is unmuted now.
Okay, any questions, Dr. Julia, if you allow me?
Yeah.
Hello, how are you?
Fine, thank you. I have first a question. If I have a lady bleeding and she's under spinal or epidural anesthesia, when I should decide to change her to general? Which one?
I think if the surgeon's having difficulty, you need to maximize the relaxation conditions in the abdomen to facilitate the surgery. You also need to be able to concentrate on your fluid replacement. So at this point, I would send the patient just to make the anaesthetic management and the surgical management easier.
Okay. The second question is, if I have a lady with a chronic hypertension and how can I know if she have a signs of pre-eclampsia according to her blood pressure? What's the baseline should I take?
Well, I think that's a very good question. It's also a difficult one to answer. She should be on medication anyway, so you may need to look at what her booking blood pressure was and then see how it's changed during the pregnancy. But it's always better to assume that your patient has preeclampsia and treat them accordingly, even if it turns out that they don't.
Thank you. Third question, Denise, if we start to give it to the patient with signs of preeclampsia, do I need to continue for 24 hours or the protocols that I can obey? Follow?
24 hours of magnesium is recommended. I also need to look at the clinical course of the patient. Once the patient is delivered and that placenta is out, they will usually start improving quite quickly. However, in the UK, at least a third of fits are postnatal, not after the birth of the baby. So you have to be extremely vigilant, and there's no harm in continuing it for more than 24 hours as long as that you're monitoring the levels or the reflex activity and you've got them in a high dependency area.
Do you recommend that to keep the patient in, let's say, in gynecological department after the C-section with the preeclampsia signs, or to transfer it to ICU or to observer unit?
I think depends on your depends on the training of your nurses and midwives, hopefully in your hospital. You may have a set of midwives who are familiar with obstetric high dependencies. But if there's any doubt about the level of care, I would recommend sending them to intensive care. Like I say, postpartum hemorrhage and eclampsia account for most admissions of recently pregnant women to ITU in the UK.
All right. Other questions, please. Now, as you all know, Dr. Julia Siddall is leaving tomorrow night. So we will have to make the lecture at 6 p.m. I'm sorry about that, but that's how it will have to happen. Julia, is your lecture tomorrow fairly short, or?
Yes, we're just going to look at sepsis and influenza.
Influenza and?
About thrombosis.
Okay. Oh, thrombosis and influenza. Okay. So it should be fairly short. Tomorrow the lecture will be at 6 p.m. I will post the link. Right now after we finish this meeting on the Facebook page. Please look out for the link. It will be 6 p.m. باكر إن شاء الله السبت. المحاضرة على 6 مساء لأن الدكتورة جوليا محتاجة تروح للمطار، تطلع على المطار مش بعد الساعة 8. اوكي، فاستحملوا معانا معلش مرة واحدة.
اوكي شكرا.
Also, since you have had such a dense month, 1 month of 2 lectures per week, next week is off. So I'm not giving a physiology lecture. I'm not giving a respiratory physiology lecture next week. I will not. And I will see you the week after that. I also have a week off in in April, because I have to travel. So we'll see you tomorrow, inshallah. And next week there is no lecture, Friday or Saturday, either then. Okay? Okay, yes, some rest. Yeah, you need to digest all this information that you got from Dr. Keith and Dr. Julia. My God. Hey, you are all now unmuted. Please, let's thank Dr. Julia. Okay. All right. Hadil, Hadil, do you have Skype? Attendee self-muted. Hadil, can you unmute yourself? Just tell me if you have Skype, and send me your Skype name. I'll look for you, and then you and I can talk. Is that okay? نحكي أنا وأنتي على السكايب في موضوع اسمه. You said that we have to restrict fluid. Wait a minute, Mustafa has a question before we disband.
Yeah.
What did Mustafa have to say? Julia, you said that we have, can you see on the side there where it says cat? We have to restrict fluid to 80 mils per hour, and that including all the fluids she can take orally and IV. Is that enough for pre-eclamptic women?
It's absolutely vital because we've been doing this for the last 10 years in the UK, and we have eliminated death from pulmonary complications of pre-eclampsia. And it won't, whether you go on to develop renal failure is independent on how you do the fluid management.
All right, peeps. Good night. We'll see you tomorrow, 6 p.m. Julia, bon voyage, have safe travels, and we'll talk, huh?
Thank you.
Okay.
Bye.
Bye. Screen share. half semi. Yeah. Maybe presented on screen.